So everybody, it looks like we're going live. It's 3 o'clock EST in the UK. Most of our lovely doctors and gynecologists here are based in the UK. I'm the only one that's actually based in the US. It's lovely to have you all. I am absolutely thrilled to have this panel because it's rare that we can have this extra time with doctors and gynecologists and be able to sort of sit in your brains for a little while and have some of your knowledge. So thank you so much, Rebecca. You saw the film and invited me to do this panel with you, which is really, really exciting. So thank you so much. Most of you will know now, if you're on our site, you've probably watched To Kid or Not to Kid. If you haven't, you can go to the website. We've actually at the moment got money off voucher, so we can give you the login if you haven't seen the film because you've been watching today, which is awesome. And yeah, so you know me, I'm the director of To Kid or Not to Kid. You've seen plenty of me in the film. And so I'm going to pass you over to Rebecca and then Georgina and Amy, if you don't mind introducing yourselves, and then maybe saying actually what your impressions are, what your impressions of the film were would be great too.
Okay, thank you, Max. So I'm thrilled and so grateful to you doing this for us. It's just so exciting to see you again and to hear about the film. So thank you. Never mind thanking me. Thank you. And my name's Becky Fulgham. I'm a workshop GP, and I split my time between being a GP and running a charity that I set up a year or so ago, which promotes sexual health education and the importance of family planning to young teen boys and girls, and helps them draw in wider issues about planning a baby, like looking at population and the wider world. And then we tie in all the kind of autonomous issues around that, so mental health, contraception, well-being, all that type of thing as well. So that's what I do. I split my time, and I have a specialist interest in family planning and sexual health. So I do coils and implants, things like that. So your film, I mean, you've heard me say this to you before. I love your film so much. And, you know, one of the many reasons I wanted to do tonight with you, or this afternoon with you in the States, is I just wanted another run up at getting your film out there, kind of on my patch, so we can get a wider reach between us, because it's such an important film. And anyone who has these kind of preconceived ideas or notions about it, I just say watch it. Just watch it from beginning to end. And I just found it such a fantastic and meaningful and balanced bit of filming. I was just enjoyed every minute, and I reflect on it often. And I watched it again yesterday and loved it even more watching it through the second time. So that's me.
And now no pressure anyone else for saying what Rebecca's just said. You know, if there's problems that you've seen in the film.
No.
But thank you, Rebecca. That's lovely.
Okay.
Georgina, do you want to introduce yourself?
Okay. My name's Georgie Fraser. I'm a consultant obstetrician and gynecologist in the UK, OBGYN, isn't it, in the States. And I do obstetrics, specialise in postnatal and perineal injuries. And in my gynae practice is mostly urogynae, and also sort of encouraging women's health, especially as they age, and the choices and HRT, etc. So all those kind of elements of women's health. And so I actually know Becky for a long time, and she introduced me to this film, and I was it's something which I suppose we promote women's health, and it's something that I kind of considered about the choices before, but I think I was really struck by Maxine's film, and it's made me think very differently about women's choices, and actually slightly how possibly old-fashioned we are in our approach to treating women who don't want children, who choose to not have children, and how society treats people actually, and the importance of choice. So yeah, I mean, I was blown away by it as well. It's amazing.
Thank you. And I love that as you were saying that, Georgie, everyone was nodding. We were all like, yeah, it's so old fashioned, you know, and I was watching you all nodding at that. So thank you. Thanks so much. And Amy? I think Amy's frozen. No, we're back on.
Froze, and then we've unfrozen. Hi, yeah, I'm Amy Kirstein. I am also a GP like Rebecca, and I work in Buckinghamshire. And like Rebecca, I have a particular interest in women's health and contraception. I also fit implants and coils, and I have a conflict of interest to declare, which is that I do have 2 boys who are hopefully currently sleeping and won't come in and interrupt this recording. And I think, yeah, reflecting on the film, I don't think I realised how much I needed to see it until I started watching it. And it made me realise that it is 70 years since the pill was launched, and actually it feels like that is still a very fresh conversation. It still feels a bit taboo. It still feels that talking about whether you want to have children or not is something we're not very familiar with. So I am a big fan of getting people to talk more about things. So I've made some podcasts to try and get women talking more about contraception. So I think talking more about this topic is something I am a big fan of.
Well, I know just with your comments here, I know you've already now got tons of fans from the child-free community. I'm really grateful for that, because we don't get, as I mentioned before, we don't get a lot of this opportunity to do. So we do have questions coming in. And I love, Lucas has actually, I'm looking at another screen. So if I'm looking to one side, everyone, it's just, I'm looking at your questions as they come in. But Lucas is a gentleman who's also child-free. He runs his own child-free site, which is awesome, because it's great to have the male voice as well. And Lucas is saying, ha, that's not a conflict, Amy. And that's a really lovely, I'm really pleased he mentioned it, because I wanted to say it too. I think there is often, I think people get so worried that we might upset each other from those that have children, that those don't have children. And that's also what my film was hoping to do, was like, listen, you know, we're all in this together. I also love, I'm going to tell a very, very quick story before I start with the questions, that one child-free person was actually promoting this event on her site, and a parent responded saying, oh no, we hope we're not trying to treat people to change their minds to not be child-free. Because she said, I think child freedom is like a fantastic choice, and I have 3 kids, and I really don't want this panel to be about trying to like change anybody's, which was really lovely. When I read that comment, I was like, oh, there are so many parents out there that are really supportive of our choices. It's just, unfortunately, we come up against a lot of stigma, and especially when we are trying to get treated for, you know, our sexual health as well. And so some of the questions, needless to say, is, so Melissa Noonan, she doesn't mind me using her name at all. She's writing from Australia, but I think we could talk about this worldwide. But she's saying, from a patient's perspective, what can you do to make a GP, or primary care physician as known in the States, and gynecologist feel we're making an informed decision and enable them to move forward with permanent contraception? Do you want to start off with one of the GPs first, because it sort of sits with you first and then it goes to Georgina, right? So I don't know, Amy or Rebecca.
I'm not sure I fully understand the question. She wants us to feel that we are convinced by their permanent decision.
Yes. Well,
so
what, from a patient's perspective, what can we do to make GPs and gynecologists feel like we as a patient are making an informed decision? So you wouldn't, as we come in and say that we're seeking permanent contraception, you wouldn't go, well, you know, what could be some alerts for you if somebody's coming into the room? You know, is it, could it be age? Could it be you feel that, I mean, I don't know. I don't want to put words into your mouth either.
Okay. So I think it's a real shame, isn't it, that patients are now asking what they might need to do or say or be in order for us to hear them, what they're actually asking. So that's a shame. So I apologize on behalf of all doctors across the world, because I don't think that's what we'd ever like. But if we're looking for, so we should be listening to individuals. If that woman is sure that she'd like a permanent form of contraception or sterilization, or if that's what she's meaning, then that should be enough. However, there might be things like age that might make us explore it, or ask that patient if they wouldn't mind thinking on it for a little bit longer. For example, if it was a youngster like Megan in the film who didn't have any children and was young, so there's plenty of neuroscience now that the under 25s are still relatively, in a neuroscientific perspective, from that point of view, in the teenage state. So there's the prefrontal cortex, the front part of our brain, which we use to make complex decisions and future planning and abstract kind of nuanced thought, that takes up into our mid-20s to fully form. So if I had, say, a 20-year-old in front of me saying they wanted permanent contraception, I would never want to be patronizing, but I would want to maybe possibly ask if they would think about having long-acting reversible contraception like the coil, and in a few years' time maybe revisit the conversation. But I don't think it's anything we can manhandle. I don't think we're certainly not in any position to judge. But yes, age would be a big factor, but also how they are psychologically, if they're feeling well. You know, if they've just been through immense trauma and this is part of their reaction to it for whatever reason, again, we might want to buy a bit of time. But I hope we'd never be in a position to try and make patients change their mind or justify that request, because that's just not right. That puts patients off coming to the doctor, and that's not right. So I feel a bit depressed by that question. I'm sorry. But yes, there are, those are the elements that would be going through my mind. I don't know what Amy and George think.
I think I kind of know what you mean about, I think actually even as doctors, when I go to the doctor, I worry about what I'm going to say. And I think it's fine to feel like that and to write things down and show you're working. And hopefully the right kind of doctor should be giving you all the chance to get all that off your chest and to kind of explain all your thoughts and your feelings and your things you don't know and the things you want to know. And I think if you get to the end of a consultation and you realise that maybe the GP isn't quite getting where you're from, it is absolutely fine to say, could I talk to someone else? Because I know in our surgery, we've all got different specialist interests. I know I am not a great men's health expert, so I am very happy when a patient goes, is it all right if you talk to a colleague about this? And that is fine, you know. Feel free to get second opinions and to slowly build up your confidence in the decision you're making.
Would you have, because you talk about the delay, and I know, Rebecca, you saw me talking to Megan in the film and saying, you know, she was walking around with this file of quotes. Is there a time period? Because, you know, obviously as soon as somebody hears, oh, they've got to wait for, you know, an amount of time, and, you know, would you sort of say, okay, and that this may be hard because obviously it's so individual for every patient, but how could they then come back and, you know, reinforce? Because this is a big issue in our child-free community of people not being able to take us seriously. And I wonder what steps could be put in place to make you feel confident in our psychological health and the right age. Could there be a time period? You know, could we create some kind of checklist? I don't know. I mean, these are big issue subjects. So I don't know whether this is even easy to answer, because I know sometimes, especially in the UK, you know, there's financial reasons that the NHS, you know, we're not incredibly well funded either, and it can be very different from the US. That was a very long-winded, I wasn't, you know, so no,
so it's fine. I get the gist very much. So I think defining a time period would be quite tricky because every patient's different. But I think from a doctor's perspective, if you've got a patient, and you need to be persistent in using the NHS in England for all sorts of things. If you want it, you keep coming back and you fight for it. So it's not just for, you know, permanent sterilization, there might be other areas of your health that you are adamant you would like something done and you want to be listened to. But in this area, every woman's very different. But from a doctor's perspective, regardless of age, probably in this context, if someone kept coming back and saying the same thing, and that's saying to us that they're not being heard, I think that's valid. And I think there has to be a time when doctors say, look, this woman knows her own mind. We can't keep trying to buffer this by protecting her from a choice that she might regret, because I don't think we're in a position, we shouldn't be saying that to a woman anyway, really. So I think everybody's very different, but the persistent nature needs to be listened to and reacted to. And certainly if you are, you know, if you're mid to late 20s or early 30s and still saying that, we've got to listen and do it. And I felt very sad for Megan, because I think she was led to believe if she lost the weight, she might be eligible for the surgery. But what it turned out is that she lost the weight and they thought she'd now be eligible for IVF. I thought, no. I really did feel her frustration. Sorry, what wasn't a very good answer, I don't think, Max, but I think everybody's different. And if someone's persistent, they must be listened to.
Yeah, I mean, what are some, you know, I'm trying to include some of these questions here because I could just be asking you all questions the whole time, just from, you know, the filmmaker covering this issue and being child-free. So I'm going to try and bring it back to some of the questions as well. And you just mentioned regret, and actually Megan wrote in with a question saying, you know, do you get a sense, and maybe this is more for you, Georgie, because you're dealing as well with people after they've given birth, but do you get a sense of people expressing regret about having a large family size more than actually not having families? Because we get this regret thrown at us a lot, like you're going to regret your decision, you're going to regret your decision. And Megan's is saying, you know, why does sort of the regret sit with us as child-free? Is it also regrets for some parents that are like, you know, I just shouldn't have got the, you know, 5th pregnancy, you know, this was a mistake, you know. I don't know whether our patients is honest enough to admit.
No, they very are. So I'll often be sitting in an antenatal clinic and seeing the lady who's on her 5th pregnancy. I was waiting for, often in the UK, you go to your GP or family planning afterwards, and maybe they haven't managed to get there, or they didn't think they would conceive because they'd been breastfeeding. We see that all the time. And they have 2 under 2, and then I go, how am I going to cope? And sometimes it's difficult after having a baby, because once you've had a baby, you're exhausted, you're tired, and a lot of these ladies will say, I don't want any more, we don't want any more. And you're very much, but what you do worry about regret. And then you'll see them back in clinic. And when you see them back in clinic, they're like, oh, how am I going to cope? And sometimes they'll be sobbing away. And I've started even sometimes writing letters to the GP whilst they're pregnant to say, right, see this lady 6 weeks afterwards and start. So in the UK, we have to get specialist funding, which comes from the GPs, our primary care, and start the process rolling so I can do it sort of 6 months afterwards, and it's in place. And back to the previous conversation, Becky, about sort of your comment about within primary, so within your GPs and in the States, it's often you often form a better relationship with your patients than we do, because we're secondary care providers. So we don't know the nuances, we don't know them very well, and so we can be just faced with people. And so it's about communication. So as Becky and Amy said, it's very easy sometimes just to pick up I'm a great believer in picking up the phone and sort of saying, actually, I know this lady so well, she's made this decision, she will not have regret. And that provides me with almost sort of that reassurance that I'm not on someone I really don't know. I don't have that relationship that I'm going to perform. If I'm going to perform surgery on them, then I need almost someone who's got a better relationship to know, actually, there won't be any regret here. This is the right decision. And then I will probably go and discuss it with another one of my friendly colleagues and say, this is a situation, can we meet her together? And there's, you know, it's about teamwork really and communication, I think.
And they say, don't they, just playing devil's advocate, that the only way to remove regret is to remove choice.
Yeah.
So we're giving choice. So you get the same effect, that you're not able to get pregnant whilst a long-acting form of contraception is. So it's providing the same outcome. You shouldn't get pregnant, but it allows more time for choice.
Yeah.
Yeah, there's a report that's was written in the US, and it wasn't. It was talking about regret of all women with pregnancies, and it didn't specify child-free or not. And so I think sometimes without the, in your experience, we need sort of more voices saying, well, actually, it's not very common that the child-free possibly regret having permanent sterilization, but maybe some mothers that had permanent sterilization, because it seems that all the attention seems to be on us, the child-free, and I get confused by that, because I don't know where the regret comes. And in your experience, I don't know whether the regret comes from, is it parents or is it mothers not getting sterilized before that, or are you seeing it more with the child-free?
I think our job is full of seeing people who have made all sorts of life decisions that they want to go back on. I think as Rebecca was saying, that's life, that's part of choice. And sometimes as doctors, we care so much that we desperately want to protect people. And we've seen things that have gone pear-shaped one way or the other, people having kids who don't want them, or people not having kids and then changing their mind. And we want to protect people, but I think actually we just have to, it's what my mum described as being an honest broker. We just have to kind of lay out the options and let people get there by themselves, having enough information, having enough time, having that freedom. And perhaps we need to stop being so scared for you and just let you guys make the decisions that you need to. But, with the right support, obviously.
And we, in the UK, it's not such a litigious, I kind of think in the US, some doctors are worried because they think they could be sued. But you rarely hear those stories. So, but thanks, Amy. And we are getting more questions in live. So Catherine Heckett is asking, out of interest, would the panel care to comment on whether legal liability fears for the future might be one thing, making physicians less convinced immediately, or is that perceived? And I guess it's not such an issue. I know financial can be an issue in the UK.
No, it's still an issue. So it's becoming, in the UK, we are becoming very medico-legal, especially in the surgical specialities, and we all have insurance, etc. So yeah, I'm afraid there is an element. If I performed a sterilization procedure on a young woman and age 35, she turned around and said, but you didn't counsel me properly, and I don't know, I've met a new partner and he's desperate for kids and I can't give him kids, and you didn't tell me this and you didn't explain the reasons, and I was vulnerable at that time, there is no doubt about it, I would be liable. Would you agree with me, guys? I think I would.
Well, I think it all falls on the quality of your notes at the time, and like Amy says, life changes, our minds change. But yeah, I suppose we're less litigious than the States, but yeah, we do have to be really careful that whatever conversations we're having in real time, we're documenting them thoroughly. Especially if there's a suggestion of a patient being mentally vulnerable at that time. It's a shame to practice like that because it's defensive medicine, isn't it?
Absolutely. And the times have changed, unfortunately. And yeah. So yes.
I think we're slightly protected by the system in the UK at the moment, where most sterilizations have to go through a panel where you explain why this patient has particular reasons for wanting it. So maybe that gives an extra safety net.
Yeah.
But I know from the position of people wanting sterilization, for example, it will feel like kind of a hoop to jump through rather than a safety net. But I think it probably works a bit of both ways.
Yeah, I think the issue as well, Max, is that in this country, they don't fund usually a reversal of sterilization. So that would be something that patient would probably have to pay for. And I think you'd have to signpost the whole journey, which might feel immensely frustrating and horrifying to someone like Megan, who is so erudite about the fact she is child-free. She was almost born child-free, Megan. She's so compelling. That would be offensive to her, I suspect, walking her through that journey. But she'd probably just have to take sympathy for the doctors in that situation, the kind of hoops we have to jump through on the basis of all our experience or, other cases that we or our colleagues have told us about or documented.
And this is why it's great to have a panel like this, because I think it has to be discussed much more openly and with people that really treat us that and I know it's often so hard, we put a lot of weight at the doctor's feet, but at the same time, Megan is now 5 years later and had to go through an abortion recently because she wasn't taken seriously. And for me, as somebody that knows her now very well, I think that should be litigious, actually. The fact that she's been through something for some women, for many, it doesn't affect, for many women that have had abortions, it's a form of their birth control, but for others, it can be tragic. And I was on the floor when she told me that, 5 years after seeking her first appointment, that's what she's had to go through. And she has had a letter, she's still waiting. Obviously, the pandemic has really slowed everything down. But I really want to make sure that never happens again to another.
Absolutely.
Yeah.
And I would hope in the UK, Max, even at Megan's age, what is she, 25? How old is Megan now?
She was 25 when she started, and she said she only started, really to your point, Rebecca, which I think is really interesting. She knew she wouldn't be taken seriously till she was 25, and now she's 30.
Clever Megan. Well, yeah. I would hope that now she's had to go through an abortion, which I wouldn't wish on anyone, but like you say, some fare through it better than others. That in itself would get her straight through any type of panel procedure in the UK. I mean, what more does she have to show or go through? And I think UK standing up against the States in that situation would probably be much more sympathetic there. I'd hope their threshold for putting her through now here would be very low. They'd say, right, that's it now. We need to do something. Don't you think, Georgie?
Yeah, I think, and I do think that. And again, there are safety nets, and their safety nets are there. The safety nets are also to support us doctors. So the panel's there to support the doctors, the GPs. It means that we can all say, actually, this was the right decision for this woman. One of the problems is risk assessment. So unfortunately, we can't do sterilizations laparoscopically under a local anesthetic, which would be perfect, but we just can't. So there's other parameters to think about. So if you're offering someone a laparoscopic sterilization, and they've had major bowel surgery or other surgery on their abdomen, actually, there are risks, and they are quite significant. If you put a little wee telescope in the operation takes about 10 minutes. It's very straightforward. But if you put a wee hole in the tummy and go into another organ, and they are very unwell, or there's breathing difficulties from the general anaesthetic, they're huge risks. And that's why, as surgeons, you were like, is there anything else? What are the other options? Is there a copper coil? Have they tried the Mirena? And it's not that it's more risk assessment, and on the other side, if you see what I mean. So there's the choice, but there is the element that we don't, one of our oaths is do no harm, and actually to do harm in this circumstance could be, it can be devastating. Normally, by the way, they're fine, but it's just, I'm being quite dramatic, so don't all think.
I'm gripped.
Yeah, normally it takes me 15 minutes and you're out, so it's fairly straightforward.
We have a lot of people engaging, and we have some more questions. Personally, from my point of view, I think there's not enough that have been invested in male contraception. And I know that takes away, our empowerment of how we want, how women should control their own bodies, and that empowerment. but the fact that men only have vasectomies or being able to use other, the one other method of contraception. And so we did partner with the Male Contraceptive Initiative that are trying to bring out and develop gels, etc. And they were halted, as I'm sure you all read, because of their side effects. And we've dealt with these side effects for years and years and years. And one of the reasons for all of you that watched the film that and learned by my mistakes, I decided to come off the pill. I didn't want to pump myself with hormones, so I used the pull-out method, which is not a method. And
What method?
It's not a method. It's not a method.
It's not on the list, Maxine. No.
It's not on the list. So I was able, over here, you can run to the chemist and get Plan B, the morning after pill. I don't know, is there an amount of time you're meant to, how many morning after pills can you use? How easy is it around the world to get hold of? It is pretty easy here, but you have to pay $50 to get a morning after pill. So can you talk a little bit about that? Because that is another, form of contraception that, if we're waiting for, if we've decided that we really want permanent forms of contraception, aren't getting them, what are other options? And I wonder about morning after pills.
Becky, do you want me to take this one? Or
yeah, go.
So you can get the morning after pill very much so in the UK. So either from the chemist, although you do in most cases have to pay for that. You can get it for free from your GP or sexual health clinics. So hopefully it is there, because we know that people not only need it, but they need it as soon as possible. But yes, we know it's most effective if it can get into you before you've ovulated. So at certain points in your cycle, and it stops working so well if you've taken it more than once. It's not a complete rule out. So if in doubt, go and ask. But it's definitely not ideal. And it is quite a big wallop of contraception, wallop of hormones comparatively. So that's why I know some people love the ideal, the long acting, so really good at stopping you from getting pregnant, don't have to worry about it every day, but reversible, so you can completely change your mind. And that's the gold standard. And it's why I know many of our patients love the different kinds of coils that can have very low amounts of hormone or none getting into your body. But I know they're not there for everyone. And I know that many people watching this will be going, I've already tried it and it didn't work. But there are many women who tell me, especially after the Mirena coil, because it often stops their periods, they go, oh my goodness, that was life-changing. And the great thing is that those women who go, I hate this is awful, we can take it out. And its hormones disappear out of your body almost immediately. Like, bam, you could get pregnant from sex you had 7 days before you take the coil out. That's how good it is at getting you back to your fertility afterwards. So I think that's why we love it, because we've seen it in action, but we know that many of you have tried it already and it's just not been the right thing for you.
And I'd just like to advocate that with the Mirena coil. I think it's very good. We get to use it for pelvic pain, we use it for heavy bleeding. And again, and the other thing you can use it for is when you start dipping your estrogen in your 50s and the menopause comes across you, you can put some estrogen on as for HRT and you're protected on a patch, so you can keep it going. Yeah, so there's much more. The other thing I just wanted to mention, Amy, I can't remember but you can also use the coil, can't you, as a contraceptive method?
Oh, that's so important. Yes, and I always forget it. Yeah, the copper coil, even better than the morning after pill. You've got more windows for opportunity. And you're right, it's so often forgotten, as by me this evening. So yes, an absolutely brilliant one. And just to say, we are not paid by Mirena or any coil companies. None of us, I don't get paid anymore by the amount of coils I put in or anything like that.
I would love to be paid by Plan B, because I would be, I want to be the Plan B face. I really do. I don't mind.
You said it now, Max.
Yeah, exactly. So we are getting some comments. Terry Roberts says, great to have all this information, but we actually don't want our fertility back. So it's interesting. Like, we are trying to be treated for not having children, and I think quite often in Megan's case, she was being treated still with the anticipation that she may have children, whereas she was, hey, she knew herself so much better than I did. You know, it wasn't until I was in my 30s, early 40s, which is crazy, that I really knew my own mind and what I wanted out of life, you know. But she knew from such an early age. So I'm just wondering, you know, how we can, you know, the coil, we know, like you were saying, Amy, it is amazing for so many. But when for somebody like Megan, who does get the side effects of depression and weight gain, etc., from hormones, what other, you know, there are so little choice apart from that. And I guess you sort of answered it by saying, you know, with your, you know, my heart's always, I have doctors in my family and I know what you're up against. You have sort of like, not even 15 minutes, you have like, what is it? You know, the time, 5 minutes, right? But to really
we can
listen,
stretch it out. We can run late. I do often.
But that's not easy. And I know with Megan, or in my experience when I was in the UK, I'd often see a different GP as well. It was like who was on, who was available, because the best ones, right? You guys will probably always be booked up. So it's who can see me when I need them. So I love this, you know, trying to get back in, maybe always to like try and see the same doctor, the primary care physician. And then what can there, I liked your conversation, Georgia, about, you were talking about phone calls. I mean, is that really a reality? You know, can you have phone calls with the GP? Do you have time? Yeah.
So yeah, you know, so I will do events in my area where I kind of hope before, no, but I think that we are coming through to a different time now where we're much more emails. So people will like actually speak to my secretary at work and say, would you mind giving this GP, or can I give you my email address? And I mean, it's not regular we do, but it's becoming more like that. And I think as we develop closer relationships, then actually, I do think times are going to change, and picking up the phone should be, I mean, neither I don't work with any of these guys as GPs, but I do have GP colleagues who I regularly get phone calls or WhatsApp saying, eek, have you got any advice on this? And I'd be like, yeah, fine, just do this. Or I'll speak to my secretary and we'll get them into clinic or something like that. And for me, it's quite common practice. From other doctors, that won't be common practice. And I suppose it's the individual, isn't it? And we're more probably a bit younger, a bit more modern, and I'm okay with doing things like that personally, but it's individual, isn't it?
Yeah, that's great to know. I mean, and from the GP side of this.
Yeah, I think it's trying to be an advocate for our patients because actually it's the patients who aren't listening right now, the men and women who don't know about this chat and don't know that this is an option. They're the ones that I really worry about, and who will come and maybe not even have the right way of expressing how strongly they feel about wanting to be child-free, and they're the people we really need to stand up for. It's something that's recognised all across medicine, so it's called the inverse care law, that the people who most need the stuff find it hardest to get the stuff. And I think that's probably true throughout the whole world and all sorts of things, but it's definitely an issue in terms of this, that we need to think of ways that we can talk to the Georginas all over the world and stand up for those patients who might find it hardest to do it for themselves, really.
And the lovely thing was for Megan was that she did her primary care physician, her GP, did actually write on her behalf. She didn't ask him, which was lovely, and wrote to the gynecologist to try and, you know, be that the person alongside her, but, you know, alas, didn't. And then she ended up seeing a number of different GPs as she was going through the process and getting more letters. Talk a little bit about what are the other barriers to, you know, Georgina, I was really interested that you mentioned that the operation, actually, as long as you haven't had too much, like I wouldn't be a good candidate because of all the operations I've had on my womb and etc. But it sounds like it's less hard than like the vasectomy. When I was filming the vasectomy, I was stunned with how quick it was. And, you know, it was, like you said, laparoscopic. It was just so easy. Can you compare, like, is Is it a lot harder to do these procedures?
Well, so you have to do it under a general.
Right.
We used to have something, we used to put, we used to put little coils in people's tubes, but that's been taken away due to side effects and risks. So what you do is you put little clips on the tube. Sometimes some people will remove the whole tube, but the clips method is you just literally ping them on each clip. But you've got to have, it's about getting to enter the abdomen. It's about, so thin people and also more larger people are at more at risk because it's more difficult to get into the abdomen, and you inflate it with air, and that can affect the diaphragm. And if your diaphragm isn't moving properly under a general anaesthetic, then it can be actually slightly, the anaesthetist, who's the gas man, will put the patient to sleep, can be concerned. There are risks, they are low, there's damage to other organs. But one of the other things, and I do think, so we talk about it as a permanent form of contraception, and it is a permanent form of contraception, but there is still failure rates. And that's really important to people to recognise. And it's 1 in 200, Amy, isn't it?
Yeah, I think it's 10 times higher. I wrote it down because I can't remember numbers. So for vasectomies, it's 1 in 2,000 failure rate.
Yeah.
And for female sterilisation, it's about 10 in 2,000. So 10 times as much failure for female sterilisation, which is why, again, men who are listening might want to reflect upon that.
Well said, Amy. Well said.
1 in 200. I was wondering about my maths then. I don't know.
I had to write it down in paper.
And that's actually a fairly high failure rate. And the thought is that the eggs might get past, or the clips might fall off. The clips basically work by fibrosis of the tubes. So that's why also we're a bit like, well, actually the copper coil, which is non-hormonal based, or the Mirena actually have, the Mirena is better as a form of contraception, and the copper coil I think is equivocal. So that's, and the vasectomy is better. So that's also why. And so then you're getting, once you've explored that, it's important to explain that to patients. There is still a chance. Actually, you're better off having the Mirena if that is your real thing. But if you can't take hormones, then that would be.
And there are 4 types of coil now as well. So they've got the little coil for 3 years with the least hormone, the JDS and the Skylar, I think, are the little ones. And then you've got the Mirena and Kylena. So there's 4 coils now. So we have like a tray of goodies, not just one. So sometimes if people don't suit the Mirena, because you can still be quite progesterone sensitive in the Mirena. Lots of women can say they feel moody, or they get spots on their back or their face, or they feel tired, or their breasts are tender. That will be the Mirena. I mean, there's still enough progesterone in there to make them feel like that. And they tend to do really well on the JDS, which has much less hormone and stays in for 3 years, and they barely know it's in. So we do have lots of bend and flex now, but it's just having the conversation. But it must be very frustrating when somebody knows they want to be child free. It must be horrendously frustrating. I think if we hear it enough as doctors and we document it clearly, then we're all justified in acting on behalf of that patient. But I think they just have to be persistent and have the conversation noisily, and we get the message. I
mean, we also know that NHS is cash strapped, and I'm sure insurance in the US, like, should we be paying for this, etc. So is that something that's also a barrier for you all?
So this was something we mentioned actually, and it's in the NHS, we don't actually know, like, sort of, I won't know how much an operation is, so I can just judge it from privately. But I think it'd probably be about £3,000, £4,000, because that includes theatre staff, anaesthetist, doctor. There's usually about another 5 people in theatre, cleaning, etc. Whereas, to be honest, the Mirena is £90 and it lasts for 5 years. So financially, it also makes sense. And we have a limited pot of money, especially at the moment, which I don't know.
But again, remember, unlike how the Daily Mail might make you think, this is not our personal money. We don't kind of individually, this is not affecting us. No, we're not going to, oh, thank you for going for a cheaper option. It's kind of,
we've got enough to do.
But does it mean you have to fight harder on our behalf?
Yeah,
Yes.
probably. Yeah.
But we're great at that, Max. We're tenacious little terriers.
So much time. You have so
GP
much time.
All GPs do is fight. We're great at it.
I think the GPs hold the pot of money, so
yeah,
they're the ones who have to. They probably have a better understanding of the financial implications than we do in the hospital. Whereas we're like, I don't know, because we just don't talk about it really. We don't talk about that kind of stuff. So
it's a shame. I think it's a reality that's resulted from the fact that we're cash strapped and we're trying to preserve the NHS. So I don't think it's been Machiavellian or sinister at all. I think there's constantly people with big brains trying to make sure we can keep free at the point of access. So anything that they feel is not clinically immediately necessary is going to hit the list of limited clinical importance or limited clinical importance right now, which is what's happening with COVID-19. It's just the nature of it. It's just collateral really to it, which is such a shame, but we can't give everything to everyone. That's the problem, not for free anyway.
Do you, in Megan's situation, what would you have advised? And obviously, if this is a question you can't have recorded, because I don't know how this could affect some of your work if it was shared. But tell me if you can't answer this. But when Megan was being, as you said, Rebecca, being told that she needed to lose weight in case she wanted IVF, is there a body that she could go and complain to? You know, obviously there's a local health authority, and she did write a letter, but is there somebody that she could bring on side for her as a proponent, or, you know, anything like that I don't even know whether I'm using the right language?
No, it's fine. I think you can find advocates sometimes in individuals that don't necessarily have a particular job role. I think certainly round here, sometimes the MP even gets involved and starts talking to the chief of commissioning. I think if she feels that there's any clinical negligence going on, that's something quite different. But as regards to an advocate and making her being heard, well, yes, you could probably politicize it, maybe go to the local MP or whatever that equivalent was, or who would you go to clinically, Amy and Georgie? I'm just trying to think.
You can always appeal, and we certainly had
appeal to the panel.
Appealing. So putting things back,
yeah.
I sometimes get patients to write something in their own words, like a paragraph or, you know, a page, because I think sometimes that's easier than us trying to. We can speak for you, but sometimes your own words are so much better. So that's been successful for me a few times. I kind of agree with Maxine. It is exhausting, the fact that you guys are having to jump through these hoops and we're having to jump through these hoops. And I know there must be a lot of you kind of shouting at your Facebooks going, why are you making it so difficult? And why do we have to get politicized and call our MP and things like that? And maybe that is what tonight is about, you know, just starting getting this talked more about, not to make it not have those safety nets, but to make it feel less of a burden for you people who are trying to kind of say what you want, really.
I mean, the truth of the matter is we're now becoming quite a big population. 20 to 25% of us, whether it's people infertile that have tried really hard to have children and can't have children, or those that have chosen. So we're becoming, you know, it's no more the nun who I interviewed that actually became a nun who wanted to be that didn't want children. We don't have to hide behind closed doors quite in the same way, or just, you know, not get married and, you know, be sort of, you know, find other roles for ourselves that we could still be counted as a valid member of society. You know, we're quite a chunk of, I know, right?
I think that was from the film, Maxine. I was slightly heartbroken. I was like, you know, that what there is so much judgment and it's choice, and that,
and it's nobody's business.
It's
so personal.
Yeah, it's personal. Yeah. And I think
but they made personal comments, didn't they? It was very intrusive. What people feel they're entitled to say, they should just say it in their heads and not out loud if they have to say it at all. It's so disappointing that society still does this, especially if it's a quarter of women. You were saying that's a significant and really hard-hitting chunk of society that should be listened to, and it's just bizarre, really archaic, the way some people challenge it.
But you're also going to be on the forefront of, you know, having this conversation, you know, like you were saying, Amy, being able to, you know, I can share this video, people will carry on and forward it, etc. And I know a lot of people couldn't watch live in the States. We had actually quite a lot of people really interested in this event, and I'm sure we'll get comments later as well. But this sort of feels a little bit of the beginning, you know, getting doctors together. I also showed the film at psychology conferences and sociology conferences, because it is about people that are treating us as much as our families. And because sometimes we go to those that treat us for the sort of like, you're okay, you know, especially if you're going for therapy and that's why it's been on my heart really to get to psychologists as well as to GPs and to gynecologists. So feel that you're at the forefront of sort of making change, because I really do believe change will happen. I think we are being taken more seriously, slowly but surely. I was on Reddit earlier today. We have a secret list of doctors that will perform sterilization without us going through a million hoops. And that's been a young woman, very young woman actually, she was sharing the procedure and her post-procedure recovery on Reddit. And it's lovely that there are many, many doctors that actually don't get in the way or put up barriers, should I say, and take us quite seriously. So there are many of you out there, and thank you to everyone that is out there and does listen to us. So we're nearly at an hour, and I know I said to you, listen, I'm sure 45 minutes will be done, but I lie every time I say this when it comes to this issue, because there's always so many people that want to talk. But what would you say, what could you see? You know, I've just talked about psychology conferences for me, and trying to also get the film to people that treat us in other areas and walks of life, and sharing the film with the family. But could you see, and maybe individually we could go around how this film could be used, or how your work, or, you know, can we send letters together? You know, what could you see could come from this, if that makes sense? Amy, you're nodding your head, so I'm going to go.
I'm nodding. I've fallen into that trap, haven't I? Yeah, you can already tell that I really like talking, so I want to keep talking about this. So I think one of my next podcasts will have to be on this topic, and maybe someone out there who is listening wants to talk to me about how they feel about it.
And how could they get in touch with you, Amy? We could obviously put a link to the podcast.
And I think generally everyone keep talking. I think if an issue makes or squirm, oh, sorry, am I jumping in and out? If an issue makes you blush or squirm, talk to other people about it. So find women or doctors or men who you can share how you feel about this difficult issue. And hopefully if we all get talking about it more, that should really help. I'm going to start by talking maybe to some people from the FSRH, which is the Faculty of Sexual and Reproductive Health in the UK. Some of you fellow members may be listening and see if it's something that we could find new ways to help women and men talk about. So that's my project. There you go.
Awesome.
Similarly, actually, Amy, I think it's made me think a lot more about it, and I will be speaking to all my trainees and my colleagues as well about, actually, it is a woman's choice. I think we're very much about gynecology, about women's health and promotion of women's health, and you've got to, you know, society's changing, and we don't, I've got to say one thing, there's so many important people in your video, in your film, sorry, and when they interviewed sort of Condoleezza Rice and Theresa May, I was so irked, I can't tell you. I was like, why are they talking about her fertility? It's got nothing to do with them. She's done an incredible job. As women, we have that choice. And it's misogynistic. And I think we've all got to support each other in our choices that we make, whether you don't want children, if you want 6 children, or 3 children, it's choice. And I think we need to speak more about it, and I'll be speaking to my college as well, which is the Royal College of Obs and Gynae, and see if we can do anything from there.
That would be awesome.
Over to you, Beck.
Over to me. Oh, I just wanted to say, I'm just sitting here thinking now that if I was wanting to be child-free and sure in my own mind, how frustrated I'd feel, obviously, being walked through this process, but how unbelievably relieved I would feel being sterilized, I guess, because there's no... I suspect, even despite when you're being told the failure rate, that there must be kind of a finality there that gives a huge sense of relief. Otherwise, this wouldn't be such, you know, a horrible cross to bear for child-free people. So your film really helped me find that empathy, Maxine. It was so important, and I don't think it's just applicable to you wrestling with that decision and showing us all your emotions to become child-free. I think it's a hugely important film for anyone wrestling with any permanent or accepting moment in their life, something that they feel they really have to accept and move on from. It kind of would be very helpful for all children to see how adults wrestle with decisions, and you show such open emotion, and you get such balanced decisions. So
don't make me cry. Don't make me cry on camera.
Well, I cried. You know, I cried. I told you I cried. The first time I watched it, I wept buckets. I went on this kind of emotional roller coaster with you. So watching it the second time, I was, you know, a bit more didactic with the pen and the paper. But yeah, it does take you there. And I think that's important that children see that we do feel messy and emotional, and these decisions are enormous. And we can go to bed thinking, oh, I've nailed it, I've got it. And then wake up and think, no, I'm back to where I was again. And that's really important. So I shall be using your film, not just for the sexual health element, family planning, contraception, putting child-free out there, but also showing how, you know, we do go through the motions in big decisions. I want to get your trailer everywhere because it's got such an impact. So I think I might try and get it on the tellies in the waiting room if we ever have a patient in our waiting room again.
That would be incredible.
And if I'm quite like writing letters, I think I'm going to write a few letters as well. And I'll get it out to the Royal College of GPs and anyone who will listen, basically. I mean, we're all pretty chatty, aren't we, girls?
I mean, maybe there's a one letter fits all as well that we can kind of, you know, make sure we can all sort of use it. I mean, that you know, needless to say, that all warms my heart, because it's advocates like you that can also hear what we've been going through, and you're the ones that sort of can take it. You know, who am I? I don't, you know, if I'm writing letters, I'm just a filmmaker that, you know. But I mean, I was also so grateful because, you know, all of you were sharing with different organizations as we were leading up to this event. And Rebecca, I know you were sharing with an email list of doctors, and you had a lady from, I think it was a schools advocate that also teaches sexual health.
So she's an inclusion coordinator. And so that's taking in the diversity element, so all children of all shapes and sizes and beliefs and cultures. That's the whole part of her job as an inclusion coordinator, and also pulling in PSHE topics. And this is a hot topic. This is brilliant. It's relevant, it's interesting, and it's freedom. I think young women should feel such a sense of freedom now, and I think it gets better with every day, and I love that. I could jump up and down on the spot about that. And that's the really nice thing to bring into a classroom full of girls and boys. Your video must make them think, wow, I can do whatever I want, and quite right too.
I would just think it would be lovely to have a teenager on here just to say,
wouldn't it?
You know, it's very empowering for women to say, you know, it's choice, girls, and education, and I don't need to have children to make everyone else happy. It's my choice.
And you know, for a lot of us, we feel actually we're able to give more because we are really content and happy and have made this decision. And I feel I can give in ways that I wouldn't be able to otherwise, because, you know, it's hard work bringing up children, you know, and as most of you know on this panel. So I sort of feel like I have this time and energy to be able to use, and feel so content now in my decision. And I think that's also something that we need to be sharing widely as well, is that, you know, we're really psychologically in a great place once we get through this. And after all, you know, as doctors, you just want us to be healthy, like, you know, individuals out in the world.
Yeah, promotion of health. That's the most important thing. And if that makes you psychologically healthy, physically healthy,
mentally strong, mental badasses.